Hello everyone. Wow, what you're doing in Norway sounds amazing. We're about to show you something quite similar, so I agree with almost everything you've said. So, real challenge, isn't it? We all want patients to get the right care first time and every time, right? But how do we do it? It's sort of massive system change most of the time. So I'm going to talk about CrossCover. It's our digital pathway optimization platform. We do a whole range of things from decision support in ED or primary care through to patient communications, problem sending out, surgical planning. I'll take you through step by step how we came to this. So my mission really, similar to what you've described, is empowering the staff to actually understand the problem, to fill out the solution. So I used to be an orthopaedic surgeon, and I found in my training, I used to work at St Mary's in ED. My first day ever on call was a Notting Hill Carnival, and they had me covering 3 surgical specialties, and I had probably the worst day of my life. That job is now done by 3 doctors, but I was getting a call about a general surgical problem, then urology, then orthopaedics, then a major trauma, and my first day ever on call as an SHO. I didn't know what I was doing with everything. You kind of know in medicine how to handle something when you finish the job, generally. So I was running up upstairs to different surgeons in theatre, asking them questions, just generally failing throughout the day. And then I became an orthopaedic surgeon. I went through the process of this osmotic process of learning what do you do with everything. Then I was the other side in theatre doing operations, which might be the first operation ever done, but sometimes alone, not supervised by a consultant, not ideal, while being on call, triaging stuff from ED. I'm having people waiting to talk to me while I'm doing an operation. It's just an algorithm I've learned myself. So why can't what's in my head be available to all the staff so they're not waiting to see me and every patient gets the same treatment? So the challenges we all face, massive bottlenecks in efficiency, really hard to get best practice done. I think it's 12 to 15 years from an RCT saying treatment A is better than B for it to actually happen in practice. I mean, that's quite staggering. Why can't we just be a bit more agile in our processes and get the best care that we know should be deployed actually in front of the clinicians seeing the patients when they see them? So big problem, huge variation in practice, and the variation in practice leads to huge wastage of resources. Lots of investigations happening that need to happen, lots of appointments in secondary care that don't need to happen, and patients getting bounced around and potentially being left a bit upset. So the solutions are cloud-hosted Force Multiplier, trying to fully map out all those processes ahead of time, not just the clinical decision stuff, but the entire process level to help with clerical staff. It could be seen like a quality management system for healthcare, or in some instances a fully illustrated, interactive, customizable medical textbook. This is an example of what's inside a group of consultants' brains. So this is the algorithm behind the scenes for managing ankle fractures according to best national guidance. And this is pooled knowledge of about 100 surgeons in the UK put together. There's no way every ED clinician is going to have that in their head. Absolutely no way. And that's not a very good way to show it to someone either. So when I started this, I did an audit of BOSE 12 guidance, which is how you manage ankle fractures in practice, and found that half the time, 2 years after that national guideline came out, we weren't following it. And it's a one-page document. So like most surgical trainees, I did a poster, put stuff on the wall, tried to change practice. I think the poster was taken down when Fracture Clinic was refurbished, but if you imagine trying to make comprehensive, up-to-date flows for everything all the time, you can't really do it with paper, you got to do it digitally. So this is how we display it to the end user. Now this particular pathway isn't a trauma one, this is shoulder pain for primary care. So we first started off with the emergency flows, then we went into the elective, so primary to secondary care interface. So are there any red flags? This is what they are, are they present, yes or no? Any amber flags? So we don't really assume that any clinician has the knowledge required. It's a normal distribution with everything, isn't it? So we try and break down a complex decision of what do you do with a problem to its smallest components and just guide them through step by step. And as they're going through, it's recording the clinical documentation. And this is done at a collaborative level at ICS, so we bring together GPs, radiologists, the specialists together to build these flows and coordinate them, and we fully illustrate them and make them really come to life. And every endpoint will either have a sort of a signposting, messaging for the patient. So I always have this problem where the secondary care consultants want to just stop stuff coming to secondary care. Okay, that's okay, but GPs can't discharge patients, so you need to work with them to help them keep patients managed in the community. So like here, you've got unified messaging signposting to those patients. Look, this is the plan now, you don't need a referral, but if X, Y, or Z happens, then you may need a referral, and this is what to do. Then we have endpoints that actually do require referrals, and they may go to an emergency board, the on-call team's managing, or if it's an elective referral, it will launch a predetermined customizable form for that endpoint that will go and suggest the correct ERS work list to go to the National E-Referral Service. So that means that the GPs can have their referral letters compiled almost semi-automatically with all the right data pulled from EMIS and System 1, primary care EPRs, and into the right format for secondary care with the right attachments, things like images for dermatology and reports for rheumatology all pulled in into a single PDF and goes to secondary care. If I move forward, this is a little bit scary looking, I suppose. This is actually a very simplified version of a process. So we break what we do down into various components. So we've got decision support flows that can be deployed in ED or general practice or really anywhere. And then they can have endpoints which suggest patient-initiated follow-up, and we can handle sort of through our patient-facing app, patients owning that follow-up and booking appointments when they want to themselves. Then the referral optimization component is when a referral is suggested by the pathway, as determined by the ICS and specialists ahead of time, it can put it into a mailbox or as a direct referral to our own system or into ERS. Then the other side, we've got our customizable boards to pull referrals from mailboxes, direct referrals and ERS into single workflows. So we currently supply Moorfields Eye Hospital for about half of London's eye referrals because they've got a problem where optometrists won't use ERS. So they had a single mailbox that was receiving 200 referrals a day, and it's very hard to have the governance tracking what do you do with the mail, who's looked at this email, what's the status of this, what's going on. So we pull all those emails in, remotely control the mailbox on multiple mailboxes from one board, but have tracking of who's actually working on it, what's the status, all the rest of it. We could be seen as a light EHR as well, but we can integrate with Cerner, Epic, other EHRs to write back in. And we've got a patient-facing application that we launched through NHS Login, NHS app, and you can deploy customizable flows, forms. So, for example, when a patient's referred for consideration of hip replacement surgery, we can send the patient an information, a leaflet, some shared decision-making pack, start the digital consent and pre-op assessment process. So when they arrive in clinic, a lot of this work's already done. And then on top of it, because we're measuring every step in the journey, the analytics you get out of it is quite substantial. You can start doing system-wide planning and know what are the actual flows of your patients. So we see ourselves as a development and operations platform for clinical pathways. We give you a no-code environment to design, build and test any clinical workflow. You can deploy it through a controlled governance process, full audit traceability, and you can compare different deployments with static analysis, deploys into the core workflow, so launches from EMIS System 1 or from secondary care EPRs, writes back into them, and you get that real-time monitoring of the entire flow of your patients all the time. And you see it's an affinity symbol because, like you said, transformation isn't a one-time thing, it's an agile process. And we provide a way whereby your teams can manage their own workflows very quickly and compliantly. So, for example, we have different deployment policies, major, moderate and minor. If an ICS is to deploy a new pathway for a whole system, it may have 2 GPs, 2 consultants and a radiologist sign it off. That's on a customizable rule-based sort of sign-off process. If it's just like a spelling mistake on one particular node, that would be a minor deployment. A small number of people sign it off. Our big thing really is this no-code editor. So we provide an environment to design, build and test these flows at quite granular detail. So we do provide an environment where learnings in one part of the NHS are shareable elsewhere. So you can import entire flows and entire system configurations from other ICSs in the country. So it's quite quick to get deployed, but you've got full control over every component within it. This particular view is a sort of diagrammatic view of the flow. They can get quite complex or as simple as you want. This one's probably quite a massive one, to be honest, but you can see step by step. Each decision point presents some information, gives some text, an image, a video, gives some options or links to get to the next step. And we've got a full sort of no-code editor. I think it shows in a minute. And then you can do comparisons between previous versions. So in here, it's like a block builder, drag and drop, image block, video, some text. You've got some AI that can write content for you. Obviously validated by your own clinicians when it goes live. Custom rules, you build medical calculators. We have a whole library of thousands of illustrations. We can make more to go in. But really, what I'm trying to say is we're empowering the staff going, if you've got a neurologist that wants a flow sorted, give them this tool. He can build it compliantly and deploy it safely with minimal fuss and minimal local IT work, right? It's basically the clinicians that are owning their own flows from a governance point of view. The patient whiteboards, so imagine that those flows are massive filters to your workflows. The boards are your standard, here's a bunch of patients, what do I do with them? And we've got dynamic columns, so many different column types that you can configure to whatever you want. This particular board's set up for a trauma board to book into theatres, so you can do theatre bookings, you can do clinic bookings, and you can use our UI as a maybe potentially better UI than the EPRs, but we write it and the EPR is the source of truth, or we can work standalone and be the EPR. So this is our basic patient detail view in EHR, so big timeline, full audit traceability on it, and we connect through GP Connect, so we provide secondary care with the primary care records, and if we were deployed in primary care, we can basically remotely control EMIS and System 1 and write back and pull data from them as and when needed. Clinic bookings, another aspect, so this could be deployed in secondary care or primary care or community. Clinic bookings can be driven by secretarial staff or from the pathway itself or from the patient. So a common example we had, I had in ED was booking someone into fracture clinic and say that someone's going to call you tomorrow. I hope, fingers crossed, with the actual booking. But in our system, it will bring up the availability in fracture clinic in front of the ED doctor at the time. Then you select, well, what suits you? 3 o'clock tomorrow? Oh no, I've got to take my cat somewhere at 4. Would that work? Okay, yes. So you get patient really driven booking of appointments to reduce all that, patients DNAing because it doesn't suit them, which happens quite frequently. And clinic sessions themselves, when you actually do have a clinic to go to, you can work through your clinic list and access the entire record, see what's going on. So this is more of the EHR type functionality, I suppose. This isn't the core of what we do, but it's just something we also do. Automations, we touched on it. So everyone talks about AI. We do use AI where it makes sense. There's a huge amount you can do just with automations, right? So we give you an automation builder that essentially, it's a sentence you construct with some variables going, when this event happens, then this happens, right? So your clinicians go, look, when I get a referral in, I want this form to be sent to the patient, first via the NHS app. If they don't open it within 2 days, then an email. If that doesn't get opened, then an SMS. Sort of a cascade of events. So this is an example of the patient-facing app. So patient logs in through NHS login. This one is set up for the front door to a primary care. So as a patient requesting that online consultation, so instead of the patient sitting, phoning the practice and waiting on the phone for 10, 15 minutes to get an appointment, they put in their request. The request goes through to a board that their GP or secretarial staff will man depending upon what they've decided in this flow. And then the secretarial staff or GP will say, actually, yes, you can have an appointment. Please select when it's going to be, or no, you don't need an appointment. So the sort of thing you kind of expect would already be there in GP, to be honest. It's what we expect in the rest of our lives, isn't it? A bit more control over what's going on. So this is now the clinician going into that consultation request and all the various options they have. All of this is configurable, so whatever workflow they wanted to go into that first appointment, and all the options afterwards. Also, NHS login, smart card access is by default for access to the system. So we've tried to make it as easy as possible for the NHS staff to not have barriers to usage. When I was a clinician, my biggest sort of bugbear was not another IT system, another way to log in. So we do single sign-on, reduce all that friction as much as possible. So what have we done so far? So we've deployed across Birmingham and Solihull ICS, and before we deployed, they did a service evaluation where they had for musculoskeletal care, like an OSCE scenario, lots of clinicians in the room probably. They're structured examinations given to doctors and nurses where you have a patient who's an actor who says, say, shoulder pain. They're given a set of answers to give if the GP asks the right questions, and basically got the patients, there was a commissioner in the room, watched the patient come in and leave, time in, time out, and what decisions did the GPs make. And they found that in usual care, an appointment was just over 10 minutes. The GPs got what would be considered best practice just over a quarter of the time. About half the time ordered an unnecessary appointment, and a third of the time an unnecessary investigation. But then with the pathways deployed, they got it down 30% less time in the consultation, best practice almost 100%, and a lot less appointments and investigations. So this is quite a big motivator sort of financially for the ICS, going, well, it's a huge amount of resources we can avoid being potentially wasted. So we had a health economic assessment done that basically shows about £100 saved per patient that goes through an encounter in a pathway. This is for musculoskeletal trauma. It's being repeated now for elective. So far we're at, well, that's out of date, we're at 200 NHS sites. It takes about 35 seconds to go through a flow. If you imagine how long it takes normally, if you were, say, an ED, you wanted to just phone the orthopaedic specialist on call, just to find the bleep number takes about a minute before you bleep them to ask for advice. And having been that orthopaedic specialist at one time, sometimes they don't know really what to do. If you go and escalate, and it takes 30, 40 minutes sometimes. So massive savings. But our big saving really is massive reduction in referrals. And we have, well, it depends what you define as a pathway. We've got probably thousands of actual pathways in the system. There's an RCT going on at the moment, essentially that same service evaluation, but in the real world as we deploy across Birmingham and Solihull. It's recruited all the patients now. It's being written up by Keele. Just to look at the patient outcomes, they've got qualitative and quantitative aspects to it. So does it actually improve patient care? Does it reduce the referrals to secondary care? And then the data you get is really exciting. So this is the metacarpal fracture pathway for Cornwall. So this shows you through their decision support flows in the community what percentage got discharged from flow. So there it goes 57% were discharged from the pathway. All of them would have gone to fracture clinic without this pathway in place. So that was 900 appointments per year for just one pathway, and they've got 120 deployed. So they're able to massively reduce their clinics from really staff to do other important patient care activities. Leaning on the data as well, we code all of the flows, give the ability to code them with real-time carbon and budget impacts analysis. So if you imagine all those flows is how many patients go down everything all the time, they all have a cost, a carbon cost and a financial cost. And we built this with the NHS Greener team. We won the Delivering a Net Zero NHS Award, because if you make a more clinically effective pathway, it's going to cost less money and it's going to cost less carbon. So with here, you can build live models that will run, what's the cost of your service between now and last year, when you change a pathway between this service and another ICS, and really get that sort of data on how do you stand, and really evidence the KPIs of what you're doing when you do massive quality improvement. Regulation is a huge part of this, so as we are an EHR, so it's a medical device as well. This is an example of a cancer management system deployment, very similar component-wise, decision support flows, optimized referral, and cancer tracking boards and MDT, all the rest of it. So yeah, breach analysis, early diagnosis. There are so many different variations of things we cover, there isn't really a limit. These are just a few highlights of what we've done so far. And what I've learned from transitioning from being a clinician to what I'm doing now is, these are the really important things from my perspective. Win hearts and minds, get people to understand the real problem you're trying to solve. And it's at so many levels. So we go in and we like to meet the secretaries, meet the non-clinical staff, meet all the clinical staff at different levels, because no one really understands the whole process until we go and talk to everyone, map it out and go, this is what you're actually doing. Did you know that? And like lots of you in the room, you will be some NHS champions trying to make change happen. And I find it so important to facilitate our champions. So they have to win 50, 100 battles to get any change done. So I've got a whole library of armamentarium of documents, things to answer questions. We go and meet anyone to help get past any blockers. And we're very, being agile is super important. And we found that a top-down approach, say an ICB board says, come and do X, it's not going to work unless the grassroots has it bottom up. And most of our deployments have been bottom up, so clinicians go, we want your product in to help the service. then I provide evidence to help middle management and the executives understand what we're trying to do. So thank you so much for your time. But in summary, we're just trying to improve clinical effectiveness, improve efficiency, and through sustainable models of care. But thanks very much. I'll have a stand up there if anyone wants to talk to me afterwards. And add me on LinkedIn, send me an email. But thank you so much.